Okay, so welcome everyone to this 72nd Global Health History Seminar. The topic of the seminar today is health rights as legal rights. Again, we'll have our usual format, two speakers, and the two speakers will make their presentations, and then we'll open it up for comments or questions from the audience here, and also we will have, as usual, broadcast on the internet, so we hope to get also comments from our web audience. As we are broadcasting on the web, I'd ask everyone to make sure when they speak to the microphone and to introduce themselves. My name is Human Noman, coordinator of Who Press, and I'd like to introduce our first speaker, who is Professor Richard Grimes, from the University of York, where he is a director of clinical programs in the law department. He is very much interested in how to improve legal education. He was formed in law in Birmingham with postgraduate studies at Sheffield University, and besides an academic, he's also been a practicing solicitor. He's working currently on legal education systems in Southeast Asia, and particularly in Vietnam. So without more to do, Professor Grimes.
Thank you very much for that kind introduction. I understand the medium today is through English. I'm very relieved at that, because being from my country, we are shocking at other languages. I need to tell you something before I give you the presentation that will give a little bit of context to what I'm doing. And I work in a law school where we don't lecture anyone, and some people find that quite shocking. We are the only law school in the UK that doesn't use the lecture and seminar format for the teaching of law. And the law school was set up in 2008 quite deliberately to take that approach. The reason we do that is we think that the lecture format is too passive an environment for the student to learn effectively. Consequently, we use a term that you may be familiar with, problem-based learning. We divide students into small groups. They work in those groups to address problems, and through addressing those problems, they deal with the legal concepts they need to encounter and address. And that goes on for the entire duration of the undergraduate law program. We also use the same teaching technique for our postgraduate studies, other than those that are entirely by research. And the reason I mention that to you is that it informs the way we deliver our programs, not only in terms of teaching, but in terms of the substance and content of what we do. And I want to give you a couple of examples of ways of learning and teaching that fit, I think, with improving the public awareness of legal rights and responsibilities, and not just the education of the students themselves. If at any point, given that I don't normally provide lectures to anyone, if at any point you have queries, please interrupt me. I will encourage that. I don't like standing here and just delivering material to you. I would like your feedback and comments. If you are too shy to do that, to interrupt me, please do so at the end. Okay, what is the problem in terms of making a case for educating the public in terms of legal rights and responsibilities? There is a cost to having an ignorant public. Regardless of ideology here, there is a cost to having an ignorant public, and the cost is financial, the cost is human and other resources, it affects the economy, it affects relationships, and I would add to that, it affects health. I don't know whether you're familiar with it, but Pascoe Pleasance and a number of other well-known researchers in the UK conducted some research, and in fact it's a rolling programme that's still ongoing at this moment. The last one was published, that I'm aware of, in 2006, that looked, amongst other things, at the financial cost of unresolved legal disputes. And the financial cost over a 2.5-year period in the UK is estimated by them at £13 billion. A huge amount of money, something like $3.5 billion every year. And I would suspect, I haven't seen more recent figures, but I would suspect that that had increased rather than decreased, particularly in my own jurisdiction, where the public funding of legal services has been slowly withdrawn. So there is a cost to having an ignorant public. There has been recognition on a domestic, regional and international level of the need to empower people by making them more legally aware. And you'll be familiar, I'm sure, with the Commission on Legal Empowerment of the Poor and their work. And although there's been some criticism of that report and the reports that followed, certainly the recognition of the problem, I think, is significant for us. And I think there is a consciousness now that if you resolve problems at a relatively early stage, then the cost to the individual and the state may be considerably less, but there's a severe lack of empirical evidence, which I shall return to in a moment, on that exact point. And the question therefore I pose is, how do you, if we accept that legal literacy is an important objective, how do you achieve that, and what difference does it make? Can we assess the importance of doing that? Now, I've been talking generically about the importance of having legal literacy. We refer to it in some places as public legal education. In some jurisdictions it goes under the rather trendy name of street law, some law about everyday rights and responsibilities. In some countries, these programs in public legal education have looked at very fundamental principles, issues of human rights. In others, they are much more subject-specific, work around HIV and AIDS, work around domestic violence. And regardless of the program, we find some are delivered by the state themselves. The state assumes responsibility for improving legal awareness. So particularly in Australia and Canada, there are large statewide and federal-wide programs dealing with public legal education, but in most countries they are delivered by non-governmental organisations. Some public legal education programs, and the ones I want to describe, are actually delivered in conjunction with whoever is responsible for the overall program, in partnership with law schools. Law schools provide a terrific resource in terms of the academic content and the students to help develop these programs, and some of those programs focus specifically on health law. So although I'll be talking generically about the importance of raising awareness of rights and responsibilities, I will give you an example in a moment of one that specifically links to health law. Okay, let me set out this example, and this is taken from a project I'm working with at the moment in my hometown of York. We have a group of social workers who work in the city. They're employed by the local council. They provide support for people with drug and drink dependency. Many of those people are in very, very poor health, partly because of the dependency they have, and partly for a whole host of other complicated reasons, particularly poor housing that they live in. And the social workers approached me, knowing I did work in this field, and said, would it be possible for your law school to provide some support so first of all, we as health workers better understand the laws in relation to our service users, and secondly, that possibly where individuals want help, you can address their individual health and related legal needs. So to cut a long story short, we agreed to do that work, and a number of questions arose really. What are the legal needs that are to be addressed, and to what extent is the law school competent to help in those areas, and to what extent does it complement the students' learning? Because if you remember what I said right at the beginning, we take what we call a clinical approach to learning, where we expose students to simulation and real legal problems such as this. So what are the issues of law that we need to talk about? Where might they go to for help? Because it's not simply a matter of us coming in and saying, okay, we can tell you about the law of the right to treatment, for example, but they may need ongoing help and support. So where can they get that from? And then finally, what support can they receive beyond the advice that's given, and where they need perhaps to take legal action, for example, or at least threaten that action in order to get a response from the authorities concerned. And the model that we follow is one that I would suggest to you is effective. The evidence I have for that is the evidence from those that participate in the legal literacy sessions, and a degree of independent evaluation, where we have had people observe what we do from the professional bodies, because we use this as part of the overall teaching curriculum. And I'm referring to the term clinic quite deliberately to draw that medical analogy, and what you need to think, I suppose, in your own minds is, rather than patient, we have client, but the actual context of the involvement is much the same. So what I'm going to talk about is a clinic that provides a legal service that may be about simply raising rights awareness and responsibilities awareness, but also that may go on to provide a more detailed service to individual clients. So we have, for example, from the instance I've just given you, a number of people who've attended the general information sessions who then say, well, actually, my doctor won't give me the treatment I think I need. What do you now recommend? And in certain instances where we've had the capacity to do so, we've taken on those cases and used the law as a lever, not necessarily a cudgel, but a lever where we can say to the health authority, you are in breach of particular provisions, either of domestic legislation or possibly human rights law, and would you address that for us? And in the event of you not doing that, legal action might be appropriate. Okay, so we may provide simply advice, we may go on to represent, but the whole model begins with the raising of awareness, the public legal education. And in our example, we have provided, as I've indicated already, services to the professionals so that they are better equipped to deal with inquiries from the service users, and then we have provided help to the individual clients in relation to the problems that they raise. And those problems have been very varied indeed, some directly relating to healthcare, for example, the right to diagnosis and treatment, but others much more peripheral, but impacting on health, particularly local housing conditions and entitlement to social security or welfare benefits. Okay, what are the challenges associated with this, both in terms of education of the public and us, and in terms of professional response? We must be sure in the law school, when we run a program such as this, that we personally have the expertise, because the minute we hold ourselves out, and I'm talking about UK professional regulation, but it's very similar in many countries, you must be competent to do what you're doing, otherwise, of course, there are professional practice negligence and malpractice issues. And everything that my students do in addressing the client's need must be carefully supervised by somebody who holds that degree of competence. And that may be me as a practicing lawyer, or it may be one of my colleagues. In certain instances, I've formed relationships with lawyers in private practice, and they come in on an adjunct basis and assist the clients and check the advice that's given. Okay. Particularly important to the success of the program is how we manage expectations. It's very, very difficult when you have a client with possibly a multitude of complex problems to say to them, okay, we can help you this far, but then we're going to drop you or refer you elsewhere. And it's really, really important to manage those expectations. I think it's entirely legitimate for a law school such as mine, where we teach through clinical methods, to be very clear with the client that we can provide a professional service up to point B, but beyond that, we cannot guarantee going further. And consequently, we have a written agreement with all of our clients that we help, whether they are professionals or service users, and we make sure that that agreement is understood at the outset. But equally important, we must make sure that the students involved in delivering this program, albeit under supervision, also understand the extent of that service. And those expectations will be, if you take on this case, you see it through. And we assess it academically, of course, so there is some pressure on the student to make sure they do that. We have a set of professional practice rules. Even if we are giving legal advice to a group and we're not representing an individual client, we still must maintain client confidentiality. We must be conscious of conflicts of interest. And as I've mentioned already, we must have the competence. Once those cases are taken on an individual basis, then of course issues of confidentiality must still be maintained. In my jurisdiction, not in every jurisdiction, and I know in continental Europe this is not necessarily a requirement, we must have professional indemnity insurance. So if we do make a mistake, the institution is protected, but more importantly, so is the client. And we have indemnity insurance for all of the pro bono and clinical programs that we run at the University of York. And we try to maintain, so far as possible, a continuity of service, but of course we have to fit what we do within the academic timetable, and there are times of the year, for example now, when the students have completed their assessment and they want to go and do something else, and in that instance I maintain that continuity along with my colleagues. Training and induction, very important so everyone understands what they're doing. And then finally, but probably the most important thing on that list, are the referrals. But we try to build a set of partnerships across the city and across the region where we can say, okay, we've done our bit, we've raised the awareness of the group, we've helped the client with initial advice, maybe we've written a letter, we've negotiated with the health authority, but now it's time for legal action to be taken. And in my clinic in the university, we only have so many resources and we can't take every case to its conclusion. So we work very hard to make sure that we are in partnership with other organisations, private practitioners, NGOs, other bodies, and we make sure, if we can, that we refer the clients on. What's the evidence for all this working? Lots of anecdotal evidence, but virtually no empirical studies. We do have some evidence from independent sources. In my country, the professional regulatory bodies for barristers and solicitors oversee the quality of what we do and meet periodically to check that. And they've looked at what we do in terms of clinical provision and seem happy that we meet at least professional standards. I've referred already to Pascal Pleasance's work. Hazel Gen's work you may be familiar with. Both of those authors have identified the needs of clients and the importance of raising awareness in their own empirical studies, but what they haven't done, because it wasn't within their brief, is go on to examine the impact of that. There are, however, some important studies in the field of nutrition and financial literacy that indicate whilst ever the public are being told about the awareness in those areas, then the level of the public's performance, as it were, their ability to act on the information that they've got, increases significantly. In the case of nutrition, once you stop telling people to eat healthily, they seem to revert to old habits. In my country, we have this 5-a-day campaign. You must eat 5 fruit and vegetables a day. And consumption of fruit and vegetables shot up the minute the adverts on the television were taken away. It dropped down. But more encouraging is the work on financial literacy. The Department of Trade and Industry in the UK sponsored a longitudinal study, and it would appear that raising awareness of basic principles seems to have an impact on the public's ability to then act more sensibly, if you like, or in a more informed way. Is there a way forward? Every academic who's interested in action research will say this, won't they? We need some funding, but seriously we do, because we need to systematically assess the impact of raising the awareness amongst the public of their rights and responsibilities, and nowhere more important is that than in the context of health law. We also need to be conscious of the need to develop partnerships between members of the public and community groups, between the not-for-profit sector or NGOs, and between, I would argue, the educational sector. There are in my country 100 law schools. We have a massive number of students wanting, for a variety of reasons, to do pro bono work, partly out of the goodness of their hearts and partly because it looks good on their resumes or CVs. But it doesn't matter. They're willing to be involved. They can help provide the service. So we need, therefore, to deliver this in the most joined-up way that we possibly can. And we need to be aware that there are existing networks. So something called clinical legal education, the technique of using simulation or real client work, is very prevalent in a number of jurisdictions, both in the common and civil law worlds. And there are organisations, both regionally and domestically, that provide those networks. We also have a number of bodies specialising in public legal education. In my country, it's an NGO called Law for Life. And there is an organisation that you may be familiar with, and if you're not, I would urge you to go on their website. The Global Alliance for Justice Education is a grouping of academics and activists from all over the world who have been coming together since 1999 to talk about how we can make legal education more justice-focused. And they have a conference every 2 years. The next one is in India in December of this year, and they have done pioneering work, particularly in terms of sharing ideas and materials with all those that are interested. And membership of that is free, and you can join on the website. Okay, I hope, when it works, I've given you at least some food for thought. I'm very happy to answer questions on anything I've mentioned, and indeed things I perhaps haven't. If you want to talk to me about how on earth can you teach people without lecturing them, I would suggest to you that this isn't the forum to do it, but afterwards we may talk about that, because it has caused some consternation amongst some of my colleagues. All right, thank you very much.
Okay, well, thanks to Professor Counsel for that interesting, thought-provoking presentation. Unfortunately, you'll have to hold your questions and comments for the moment because we're going to have our second speaker, and we're very happy to have Luca Burci, who is the WHO Legal Counsel, who will give a WHO perspective on health and rights issues.
Thank you. So to give a refreshing comparison between different styles, I will have the typical lecture style, where I will tell you what to think, and I will not use a PowerPoint. So is it possible to switch it off? No, off the image.
If you hit B, it should go away.
B?
No, it doesn't. Sorry.
So I can move and stand in front of the, rather than on the side.
Oh, it's just the flyer.
Then I'll move forward, providing I don't trip into it.
If you move it, I think we just turn around like this.
That's okay, fine. Yeah, thank you. Okay, thank you very much. Just to correct a little bit what Mumin said, I'm not going to give the WHO perspective. I'm going to be my perspective. And even though I work in WHO and this is part of a WHO series, this is very much my own take. What I'm going to do is, in a way, is something that I would like to bounce off with you. I don't have very clear answers, but it's something that comes out of a speech I gave last year at Georgetown University, and that I've been reflected upon because it's something I think it's worth researching and investigating for the future. And that has to do with the fact that, in particular, when I came to WHO, I'm not a health lawyer. I'm an international organization lawyer. I came from the United Nations. I knew nothing about health. I came in 1998, and I heard my colleagues, I started reading literature, and scholars spoke about international health law, or sometimes global health law. So if you talk about, and I teach a course at the University of Geneva entitled International Health Law, so I'm part of that gang. So when you do that, in a way, you have an unspoken assumption that there is a body of rules out there, a body of rules of international law that is definable as international health law. But is that the case? And if it's not the case, why? And does it matter? In a way you can compare, and I know I'm speaking to an audience of no lawyers, but if I mention international human rights law, international environmental law, international trade law, international intellectual property law, international humanitarian law, the law of armed conflicts, you're all familiar, at least superficially, with these concepts. And so, in a way, that goes to what sometimes people call the fragmentation of international law today, that the life on this earth has become so complex and so diverse that almost inevitably states create separate buildings of rules addressing particular problems. And what created a legal regime, what creates a body of law to which you can give a label? Fundamentally, first of all, a unity of purpose. Those rules, the primary function of those rules is to address that particular problem and to protect that particular value. Would it be human rights? Would it be the protection of the environment and so on? But increasingly also, given this trend to fragmentation, in many cases, there are institutions that in a way are there to produce the law, to administer the law, sometimes to interpret it, to adjudicate it. Think of our big neighbors down the street, WTO. That's what it's been created to do. So in a way it generates almost like these self-contained regimes, where the rules are interpreted and applied according to special rules of the game. So if you use this, if you want, more traditional approach to say that body of law is a regime, is a certain unity, can you apply that to health? Do we have a body of international rules that we can say, this is my turf, this is international health law? And I'm talking now about traditional hard law, the law which is binding on states, the law typically contained in treaties, contained in other instruments of this nature. If you look around, you have to conclude that the turf is very, very, very thin and consists, in my view, of the little output of WHO, which consists of two treaties, the Framework Convention on Tobacco Control and the recent protocol to this convention on smuggling of tobacco products adopted last year, two regulations that are binding under a constitution, one very technical on statistical cases of disease, and the other is so-called international health regulations, And that's all as far as WHO is concerned. If you move out, you find a few conventions by the Council of Europe, for example. There is a recent convention on pharmaceutical counterfeit called Medicrime Convention. There is another one on genetic testing, one organ transplantation, and there is even a convention on European pharmacopoeia. So it's interesting, actually, the Council of Europe has been more active and busier than WHO in creating health law. You have an environmental convention to which WHO participated called the Protocol on Water and Health. You have, to a certain extent, the United Nations Drug Convention against narcotic drugs and other substances that have a specific impact on health. And I could mention a few more, but just to give you the idea that the body of rules out there that you can call international health law, because they're being created to protect, with the purpose of protecting public health, is very limited, is very scarce. So, I'm sure the question in your mind is, why? Why do we have this state of affairs? And does it matter from a health perspective? After all, if states didn't feel they needed to create a big body of international rules on health, probably they didn't need it. The reason why, and that we can discuss for a long time, in my view, there are a few issues that can explain the state of affairs. The first is that health, for a very, very long time, was considered a fundamentally domestic issue. Is the health of my population. The fact that there is an international dimension to health was limited to the control of epidemics, because there the bug doesn't stop at the national border. But for the rest, there was a strong assumption that health was not international as a topic. The second was, for an equally long time, public health was considered as a social goal or humanitarian goal. It's something almost implicitly good for a country, for a government, to take care of the health of your people. So, but it was not seen as a development issue, for example, being so enmeshed in development policy. It was not seen as a political issue, as an overt political issue. So that also, in a way, restricted it to local constituencies. The third is that if you think of it, I mean, health is who I am. Part of me, Gianluca, is my health status. You can expand that to the level of a human community. But so health is so we are soaked in health. So in a way, it's so broad and so thin that it maybe can be difficult to see the space to have a specific instruments, legal instruments on health, with few exceptions. The fourth is the fact that WHO, that was supposed to be the locomotive to create health law, has been very shy, very timid. I just told you the little sort of record we have in terms of law creation. There are many reasons for that. I think that would take us too long. But probably, in a way, the reluctance of WHO, and obviously of our member states, in using international law as a tool to protect public health is a good part of the explanation of why the record is so thin. So anyway, and I can elaborate if there are questions on this. So the perceptions that I gave you, that I think account to part of why there is no big body of health law, changed to a certain extent in the 1990s. All of a sudden, or not all of a sudden, but in the course of that decade, states, academics, NGOs, scholars start really feeling that health is important for international law and international law is important for health. Why this change? I think four fundamental reasons. The first is, once again, WTO. WTO was a game changer. All of a sudden you have a huge package of rules that limit your space of maneuver as a sovereign state and also limit your regulatory space for health. And so many countries realized that that wasn't good for public health. You cannot treat vaccine the way you trade a car or a video camera. The second is human rights, and in particular human rights and HIV/AIDS. HIV/AIDS was the first medical condition that bumped straightforwardly into human rights because the reaction in many countries was very top-down, very authoritarian. So there was a human rights reaction to that. And many people felt, no, human rights and public health have to go together, can go together. And so there is a link and a mutual need at both ends. The third is health and development. I think that's one, I think, was a big credit of the Director General Brundtland when she came in 1998. She really placed health at the center of the development agenda. And so health acquired a political and legal dimension as part of the political agenda and as part of the development agenda. And fourth, more recent, but I think it's early in the 90s, is no communicable diseases. I spoke to some of the interns, I believe I mentioned this. NCDs, as we say, is a game changer, because they are diseases that you need to address through a regulatory approach. You need to attack the causes, the risk factors. And the way you regulate at the national level trickles up at the international level. So once again, international law and health start talking to each other. But so at the end, we don't have really, in my view, international health law. We have health and other areas of international law. So how does it play? Let me give you, in my view, what the end beside health and a few examples, and what the role that health plays. Let's start with what I mentioned before. Let's start with human rights. Human rights, health plays two different roles. It is a limit to the enjoyment of certain rights. Think of the protection from epidemics. Under certain circumstances, you, innocent person, can be taken and put in quarantine, put in isolation, prevented from leaving your country, prevented from entering a country. You can be forced to take a vaccination. So these are all areas covered by what we call civil and political rights. The protection of public health serves as a legitimate limit to the enjoyment of your rights. Conversely, health can play a totally different role. It is the object of the right. In a way, it boosts the right. And here is all the big debate, which we'll mention in a minute, about the right to health, where health becomes a human entitlement. Obviously, you don't have a right to be healthy, but you have a right to enjoy the conditions that allow you, enable you to achieve a certain level of health. So health becomes a human entitlement. And that's, to me, of huge importance, legally, politically, culturally, and so on. International trade. Once again, in Geneva, it's the obsession, there are three obsessions: humanitarian law, human rights, and trade and intellectual property. So diplomats are consumed in trade and intellectual property. And as I said, WTO was a game changer. And health here can serve, once again, in different roles. It can serve as an exception to the rules on free trade. You can protect the health of your people by limiting the import of certain products. And the GATT, the General Agreement on Tariffs and Trade, allows you under certain conditions to do so and not breach your obligations. We have agreements under the WTO package on the food in trade, the trade in food. It's called sanitary and phytosanitary measure, another agreement on technical barriers to trade. Some of these treaties have very much to do with the protection of health. For example, in trade in food and animals. In that case, health is the substance of the international standards that are to guide countries in regulating their obligations. So you see the different roles that the health plays. Intellectual property, another obsession of Geneva. In particular, the big debate was patents, medical patents, patents on medicines, patents on medical processes, patents on molecules, patents on sequence of genes or viruses, and how that can limit the access to affordable medicines, in particular for poor countries. And there's a big debate that continues to rage. The other issue is trademarks. In particular, the restriction of trademarks for health purposes. Australia has passed a law requiring plain packaging of cigarettes. All of a sudden, all cigarette packs look the same. And Philip Morris and other tobacco companies have sued for breach of the copy of the trademarks. So here you see the interplay. Environment. In a way, environment is interesting and complex because you protect the environment, and a damage to the environment, or almost always a damage to your health. Pollution, climate change, depletion of the ozone layer, persistence of certain bad products in the environment, damage the environment and damage your health. But there has been an evolution because there has been an accusation that we are too anthropocentric. We only think of us. We don't think of the environment as a whole. After all, animals and the biosphere and so on should have rights like us. I'm, of course, trivializing a bit. And so health takes a bit of a different role and needs to be assessed. The impact on health of things that also have an impact on the environment needs to be assessed. So here too there is a complex relationship, but very much part of the fabric of these areas of law. And finally, what they call the international humanitarian law, the Geneva Conventions, the Hague Conventions, the fact that the warfare is limited in good part to protect the health of soldiers that are out of combat, of civilians and so on. Some of the Geneva Conventions are there for the protection of the sick and wounded on the battlefield. So health is there, front row center in the title of the instrument. But even more, there has been a clear trend to limit or to ban certain kinds of weapons because of disproportionate effects on health and because of the level of human suffering that they create. For example, blinding laser weapons have been banned. Fragmentation weapons, fragments that are undetectable by X-ray, so they go into your body, but nobody can see where they are, have been seen as excessively, with excessive impact on health, that have been banned under United Nations Treaty. So here too, the protection of health is a limit that has to be counterbalanced with what we call military necessity in a way. The fact that war, that we like it or not, is still there. And countries want to have the authority and the flexibility to fight it effectively and to win the war. So here we are, health, all these areas of law. So, as I said, is this satisfactory from a health protection point of view? In my view, not always. Not always because these bodies of law have not been created with health as a primary purpose, have been created with other values, with other objects, trade, intellectual property, human rights, environment, and so on, that can be more or less health-friendly, but they're not necessarily, health was not the main focus. So in a way, as I said, in the administration of these rules that sometimes has its own institution, its own expert constituencies, health risks taking a backseat. Also risks to suffer from this fragmentation. The sort of certain health issues are interpreted differently in different bodies of law. In a way, we lose control of what health is about. So, and it becomes sometimes a value to be negotiated, very visible in WTO. Health is an issue that has to be counterbalanced with the freedom of trade. So, if we are not satisfied, as I'm not satisfied, what can we do? And that's what I'm still reflecting, because it's not very easy. I mean, you hit against a body of law which is there. You cannot wish it away. And this is very much a work in progress, I think. But I think there is a trend to do three things. From a legal point of view. Political point of view is another issue, but I would like to speak as a lawyer. The first is use the typical legal arguments that you use in the interpretation of the law, in the implementation of the law, to give more prominence and more unity, more cohesion to health. The second is advocate for giving a more prominent role to health in the design of new rules. International law doesn't stop here, continues to evolve. There will be new rules that in a way can and should be, in some cases, more health sensitive and health friendly. And the third is look at the space, at the possibilities for creating new health law, new law specifically for health. And just to give you, and I'll stop, a few sort of, really, these are thoughts I have in mind, but I really haven't worked too much on them. A few random thoughts on how this can be brought forward at different levels. The first is, I don't know if you heard about the theory of global public goods. That's a theory born in political economy that has a big impact because it postulates that there are certain goods that in a way everybody can and should enjoy on a no-competitive basis. It should be accessible to everybody. This theory has been stretched to the breaking point, because basically everything, whatever I like and whatever I want to make more sexy and more legitimate, I label it a public good, and everything goes. So I think it has lost vigor. But the theory as such has a very strong conceptual basis to say that insofar as certain health values are global public goods, there should not be the possibility of a private appropriation that excludes the public from their enjoyment, and with a strong push for public regulation in the public interest. The second is a trend that we see to carve off health issues from the normal working of international law. I mentioned the Framework Convention on Tobacco Control. That was a clear, strong push to say tobacco is not like other consumer products. If you use it as intended by the manufacturer, you die. Sorry for the smokers in the room. And so the idea was to have a convention to have rules that carve it out. An example is, for example, nuclear weapons and the impact on health. There was a famous advisory opinion in 1996 of the International Court of Justice of the United Nations on the legality of use of nuclear weapons. It was a very agonized thing, and it wasn't very satisfactory, but it was a clear argument that the impact on health of nuclear weapons was such that it could not be treated like other weapons. They belonged to a class of their own because of the impact on health. And so on. So there is a trend to carve off in a way, carve off certain space for health. This trend you see also at the national level. I spoke about WTO and how it restricts regulatory space for countries. Even more, with the proliferation of investment treaties, there's been an explosion of bilateral and regional investment treaties to facilitate and protect investments. So once you have a company investing in your country, you have a certain obligation to protect that investment and so on. That also shrinks your regulatory space. If you want to regulate for health, labeling, prohibition of certain products, packaging, I mentioned the plain packaging. One of the lawsuits is under the bilateral investment treaty between Australia and Hong Kong. So here too you have a clear pushback of countries to extend the regulatory space in the name of health as one of the highest social value. And we start having in international jurisprudence, for example in WTO, some statements that health is one of the highest social values and the country must have the sovereign freedom to determine the level of health that they want to ensure and they can afford to ensure to the population. So you see this trend to the way to increase the regulatory space for health. Finally, I would like to mention human rights. I said the right to health has played and continues to play a huge role. As you know, the right to health belongs to a body of human rights that we call economic, social, and cultural rights. They're a bit more difficult to apply than the typical civil and political rights where the state has to abstain from breaching your right. In the case of economic, social rights, the state has to actually be active, has to realize your rights. So much more difficult even to assess if the state is complying. But the right to health has really changed, in my view, the language, the vocabulary on which we address health issues. And there was a very important comment of the Economic and Social and Cultural Rights Committee that I really invite you to read if you have any interest in this. General Comment 14, adopted in the year 2000, that basically says the right to health has linked like this with other rights, with other determinants of health. You cannot be healthy if you don't address environmental issues, empowerment of women, education, housing, access to food, access to water, access to sanitation, access to reproductive health, and so on. So this in a way has taken health out of its Ministry of Health box and has expanded it across the whole social development agenda, turning it into a human entitlement, to which has to be confronted an obligation, positive obligation by states to take this into account. It's tremendously powerful, and I think it plays a big role in pushing this idea that international law needs to be interpreted and applied more health-friendly, also because the impact on health may breach your human rights, and so a state may breach its obligations under its human rights conventions and so on. And finally, and I think I am also abusing my time as I always do, the last point is a space for new international health law. That's something I would be interested, of course, in your views, because I wonder. WHO sometimes in the last few years had a chance of producing traditional international law, but opted not to do it. For example, we had a code of conduct on the international recruitment of health personnel to try to stem the brain drain from developing to developed countries of nurses, doctors, and so on. There was a strong push to have it negotiated as a treaty. Eventually, it was adopted as a non-binding code. We have a framework, called the PIP framework, to regulate the sharing of pandemic influenza viruses, very complex. There too, there was a push at some point to adopt it as a regulation, binding under the Constitution, as a treaty. Once again, the fallback solution was to adopt it as a non-binding framework. So there is a certain ethos against new binding law. There is a talk now about a treaty or pharmaceutical research and development that I think addresses many of the issues I mentioned, because it has to address the failure of the market to produce medicines for neglected diseases that don't generate enough profit to attract pharmaceutical companies to invest a lot of money in research and so on. So basically, the market has failed. We need a public system to remedy the failure of the market. And the public system, one of the proposals, should consist of a treaty, in a way to generate a pool of money to go into priority health research and to coordinate the use of that money. There is strenuous resistance by many countries against it, and so we see whether it materializes or not. But I'll be very interested if you have any ideas on this point. And I'll stop here. Thank you.
Okay, well, thank you very much, Luca. That was a lot of ideas in a short time. I'm sure we'll bring up a lot of discussion. So we've had two very good presentations. I'll now pass it over to my colleague from the Center for Global Health Histories at the University of York, Professor Sanjay Bhattacharya, who will chair and coordinate and facilitate the question session.
Thank you. So I'm Sanjoy, request. I can see a lot of friends, hello. When you ask questions, and all your questions and comments are very welcome, we have lots of time today for general discussion. Please identify yourself using the mics on the tables, because we have colleagues online, and I'm sure they would like to know who's asking intelligent questions and might even get in touch with you about things that you raise. So can I invite questions, comments from the floor? Carlos, please.
Thank you. Very good presentations, very interesting. I'm Carlos Dora from Environmental Health. One thing that you didn't raise specifically, and that bridges a bit the ground between literacy about these health issues and law, is the regulations that we have, the norms that we have, our guidelines. And I think they have, at least in environmental health, they have played a very important role. Most countries adopt air quality guidelines provided by WHO, although there's no rule for that. Similarly, we're sort of increasingly venturing into guidelines. Now we're developing for housing and health, for nanotechnologies, for household energy technologies and solutions. So I think that's a specific figure, if you want, that could, that does play a role in both public understanding and literacy and law. I wonder if you have any comments on that.
Carlos, you're absolutely right. I didn't address it because I didn't have time, because it would have taken another 25 minutes. Because in a way, at least as far as WHO is concerned, it's true that the main success of WHO as a normative agency is precisely to create a big, I think, authoritative, credible, and expanding body of what scholars, lawyers call soft law, which are, in a way, standards that aims at regulating certain things, but are not formally binding. And what you mentioned, and what the code of conduct that I mentioned, are all examples. I think these play a big role, and I think it would be interesting to see why, oops, I'm losing my glasses, why and how these non-binding standards generate compliance, generate uniformity, are well accepted, and so on. But it's true that it's a huge product to WHO. And it's interesting, when I joined once again in '98, and I said, WHO is not a normative agency. My technical colleagues say, of course we're a normative agency, because we produce what in public health terms are standards that don't need to be legally binding to be successful and to generate the compliance and good health results. But I think it would take too long, probably.
If I can add just very briefly to that you raise a really important point about the availability of information, particularly given the information technology we now have. My experience in running the programs that I've just been describing is that those people who are least able to cope with what life throws at them, who have severe health problems, for example, are the most disadvantaged in terms of accessing information. So a lot of the material, even though it may be out there, isn't necessarily consumed by them. And I think some face-to-face encounter is absolutely necessary.
Yes, thank you very much. Thank you for the presentations. My name is Dr. Denis Pourignon. I'm working in the Health System Department here in Geneva. And my question is a little bit between the two presentations, because as our colleague just said, there are some documents or resolutions that are not really abiding the country, but are really influential in terms of what they did. And one of the good examples that we have for the time being is the universal health coverage issue. That is something that is already translated in one of the most potentially influential tool at the country level, which is the constitution. In Morocco, for example, it has been recently put in the constitution that everybody should have access to health care. So how can we use what is happening at the country level to influence what should be regulated at the global level, and how can the global level can really help the countries in such an examples that you gave, where the client should be the countries instead of patients or citizens.
Difficult question.
That's why I gave it to you.
Okay. And I wonder what other colleagues think. To me, reasoning as a lawyer sitting in Geneva, so without a big country experience, countries are important in the normative activities for 3 reasons. First should be those who request. There is to be a need for certain standards, and the need obviously has to come not only from countries, also other stakeholders play a role, but fundamentally from our member states. The second, to provide evidence. We will keep saying that WHO is an evidence-based organization, so the evidence has to come from the countries. And the third is as a user of our standards. So that to me the role that individual countries play. And in my view, in a way, the success of the standards is measured on the fact that there is a need, a perceived need, so there is a request for particular standards, that the standards are technically credible, so they're based on good evidence, there is the stand scrutiny as a technical product, there is a perception of legitimacy of the process by which they're created, because if they're perceived as illegitimate or vitiated by conflict of interest, they just won't work. And the fourth is that the proof is in the pudding, they're used by countries. And the fifth is that they, to the extent possible, they generate a bit of accountability. That there is a reporting mechanism, some form of soft form of verifying who is using them, who is not using them, and how.
On a much more mundane level, but I think equally important, one of the challenges I set my students in working with the sort of groups I've been describing earlier is the need to identify issues for potential law reform. And they actually produce reports for me saying, well, we have this experience with the client group, we've identified this gap in the law in the UK or Europe or wherever it may be. I get them then to draft a provision that may be suitable to at least in part remedy the problem, and then send it to government, send it to the EU, wherever it might end. And it probably goes in the bin, but it's a fantastic exercise for the students to do, and that material is left with a client group that we work with, so they may be thinking about not just what my rights are in a rather blunt sense, but how we might develop things in the future.
Thank you very much, and to reiterate, very interesting presentations. My name is Rajat Khosla. I recently joined as Human Rights Advisor with the Gender Equity and Human Rights Program. I'm very intrigued, especially with the last couple of remarks that have been made, but I did wanted to go back to the presentation. And a few things that do stand out for me when we specifically refer to some of the existing and coming in from a more human rights dimension right now. Jean, you referred to the General Comment 14, which is indeed the authoritative interpretation of the right to health that we have presently with us. But it does lack a certain degree of specificity, and maybe quite rightly so at the time and space that it came out in. However, there are then difficulties that we confront when we try to use the framing of that document in different contexts. And to give you an example, one of the statements that you made, and I think which is in one of the opening paragraphs of the General Comment, is that the right to health is not a right to be healthy. Now, if you take that statement and somewhat try to apply to the example that you were giving with regard to NCDs, that's precisely what we would want people to be doing. That's precisely where we want the interventions to be targeted to, from physical activity to salt intake to alcohol consumption to when you get down to other levels. So I think what I'm trying to say is that how do we take these rather broadly phrased provisions and come to a level of specificity that can move from, a law and policy analysis to the service delivery and facility-based analysis as well. And kind of a related point, because we are talking about rights and legality-related issues, I think a key part of the mix is the non-state actors, and who are incrementally very influential in the conversations we are having. Now, I'm not only talking about the big pharma. I'm not talking only about, big food companies as such, but I'm also talking about non-state actors that tend to operate at the societal level, at the community level, as it were. And what role do you see in terms of the regulations that we are talking about and increasing of that applying to those different actors, which are usually out of the net, as it were?
Thank you. That's a big question. I totally agree, and I mentioned it. One of the challenges of the right to health, and of not only of the right to health, of social economic rights, its particular nature and the lack of specificity. It's difficult in a way even to take a state to account whether or not it's doing what it can to progressively realize the right. So, but here, to me, the importance of the development in thinking that sort of was embodied also in the general comment is that other rights can be used to support health. If you look at the litigation that I'm aware of at the national level in Africa, in Latin America, in Europe, in front of the European Courts of Human Rights, and also in the Human Rights Committee, use other rights to address health issues. Right to privacy, right to life, right to security of person, access to justice. So in a way, everything, to me, as far as they have a synergistic approach and they manage to give more prominence to health, is fine. And that was in the nature of the right to health that touches on so many other rights that it's only logical that they contribute to benefit public health. But on the right to be healthy, I still think you don't have a right to be healthy. You don't have an enforceable right to be healthy, because your status of health depends also on your personal choices, depends on how you are made genetically and so on. You have a right to enjoy the conditions that allow you to be healthy. You can have the best countries that controls all NCD factors, but if you choose to not to move a finger, to drink 17 Cokes a day, and to smoke 6 packs a day, I mean, that's your choice. And so you don't have a right to be healthy. In terms of non-state actors, I mean, I think the whole human rights movement is pushed forward a lot by non-state actors. And I think that they are also the users of some of our standards, of our policies, and so much so. I think that one of the beauties and the challenges of what we call soft law is that by its nature, it goes beyond just government. It is a product that can be used on many different levels of society, by economic operators, by hospitals, by NGOs, even by pharmaceutical and other companies and so on. So I think they do play, and they are part of this normative exercise. And I think the NGO plays a huge role in the right to health, holding countries to account, making shadow reporting on country reports and so on. So that's also a very complex interaction that I think strengthens the trend in the right direction. I would just say that.
And the only thing I'll add to that is just to stress the importance of partnerships. Yeah. And that's something that works very well for us.
Thanks for the excellent presentation. I'm Albana Nudova from the Communications Department. Picking up on your excellent idea and practice of legal clinics, I was wondering whether you would face clients, international organizations that come to you and say, we see the different levels of ignorance in our staff. Would you give us an overview of what type of legal things we need to do? And then going to Luca, internally we have 8,000-something staff in WHO globally. Is this interesting to think of a package of information materials, trainings, raising awareness among our staff, doing an internal legal clinic, things that each WHO staff member should know about global health law, the basics, where you can find reference materials depending on your function in this organization, because I think this is very fresh, innovative approach.
Yes, thank you for those questions. So far as the development of clinics are concerned, as you may or may not know, clinical legal education has been an established part of US legal education for many, many years. Some say back to the 30s, I think really from the civil rights movement in the 60s. But it's been very, very slow to develop in other parts of the world. Large amounts of American money, thankfully, have been given to enable some of that development, particularly in the ex-Soviet bloc countries. But in continental Europe and my own jurisdiction, very few clinics until relatively recently, and all of a sudden a massive explosion. when I started clinics in the beginning of the 90s, just 2 of us in the UK. Now 75 of the 100 law schools have clinics. And so to come to your point about how do you aid and promote development, there are a number of regional and national and international bodies that help do that, such as the Global Alliance for Justice Education. But I spend a lot of my time now going to other jurisdictions, not to tell anyone how to do things, but to say, this works for me, you've asked how it could work for you, let's work together. And the example I would give is the work we've been doing in Vietnam with another NGO there called Bridges Across Borders. And the work we've been doing there, they now have 5 clinics operating, and they're starting to look at healthcare issues amongst other things. So it's a model, I think, that can be exported, but obviously it needs to reflect cultural and other sensitivities. But there are machineries in process, as it were.
Yeah, coming to your question, I think that, I mean, of course, as a lawyer, I think that a little more awareness of legal rules in WHO wouldn't hurt. So at the same time, we cannot overburden colleagues with sort of big academic dissertations. But I think there are two different kinds of information that would be useful internally. The first is something that is close to your job, because technical issues are becoming more and more political. And sometimes we are unprepared when the political dimension, which is always a legal component, explodes. Counterfeit was a good example. We were caught unprepared, and we had difficulty managing a difficult political agenda. So on the other hand, there can be legal information, if you want, that should be accessible to everybody. For example, better knowledge of a constitution, some basic issues about sort of human rights, right to health, and so on. That I think could be easily part of an induction package. In my view, more to use Peter's terminology, more sort of legal awareness, without exaggerating, would be useful.
You mentioned your talk, or you gave the example that WHO in its history, even though it was given treaty-making powers in its constitution, has practically not used them. And you gave several examples of where it could have used it, and the member states basically decided not to. And the one case where we have used treaty powers, I think, was also the member states were reluctant, and we only got the treaty because of activists and NGOs and other people basically shaming member states. And it's really, again, coming back to sort of the non-state actors. And so going forwards, what do you see the role? If it's good to have international health law, then does WHO need, in a way, to engage more with civil society so that the laws, are put in place? Because the experience of 60 or 70 years is that member states left to themselves won't create international health law.
But maybe it's too, how to say, it's too negative for member states, because yes, it's true. Sort of very active anti-tobacco, anti-globalization NGOs played a huge role in pushing for the Framework Convention for Tobacco Control. But you had a number of countries that really took the baton and led the charge. South Africa, Brazil, Norway, a large number of countries, and countries also with a sizable tobacco industry, so where it was not so evidently in their economic interest to play games. So I think there's something to say about growing awareness, and that's why I mentioned NCD in particular is a game changer. The growing awareness of the huge, crippling cost of these epidemics of non-communicable diseases that have to be weighed against the viability of your industry, of your economic interest. And I think many countries, more and more countries, are looking at the scale and see that the health costs are becoming heavier and heavier. And so I think this reluctance to binding regulations will decrease. Will not disappear, but will decrease. I think NGOs are engaging already with us, like it or not. They are here, they are watchdogs, they lobby delegations, they do what they are good at doing. So in a way, sometimes we need to look how we can better engage. Sometimes it's a bit of an adversarial thing. They are a pain in the neck because they always want to do more than what we would like them to do, and so on. But they do play a big role, and they're already playing it. For example, the tobacco was an example. It's striking how still we see now in tobacco meetings, small delegations that come with one person, maybe two persons. NGOs more or less write the script, which is to me a legitimate thing, as long as the countries are prepared to make it their own. That's what happened during the negotiation of the statute of the International Criminal Court, which was immensely complicated from a technical point of view. And there were NGOs, even universities, that basically said, let me be your legal counsel, Palau, for example, or Marshall Islands, who are barely the money to send one person. And that's insofar as they play a positive role and countries are prepared to be helped in that way, that's a huge role that they can play in specialized legal field, but there is not much expertise in ministries of health.
And I will get my students to work on a treaty for international health law immediately.
There we go.
I'm Zafar Mirza from Department of Public Health Innovation and Intellectual Property. I really enjoyed both presentations. From the perspective of global health law, there is also an issue of enforcement, which we have not discussed. It's one thing to have a treaty or convention, whether it is, or even soft law. But then there is no enforcement mechanism in place for global health law also. We don't have, for example, in national jurisdictions, you have law enforcement agencies, and there is strong punitive actions which can be taken. But for global law, for that matter, and especially global health law, if, for example, under IHR, if countries are obliged to report any epidemic, and if they don't, what happens? Who is responsible for making them accountable and bringing them to the books, as we say? And what is the perspective on enforcement of global health law, if it exists, in terms of its enforcement and any punitive actions?
One big question after the other. Enforcement of international law is always an issue, because there is no international police except maybe enforcement actions by the Security Council. At the same time, sometimes enforcement of national law is a big issue. If you take the average country and you see how many rules are actually complied with, you'll be very disappointed, even with the police, with the courts, with all the heavy state apparatus you can imagine. So enforcement of the law is a problem across. When it comes to international law, and talking about the examples I made on health, enforcement is more subtle, is more decentralized, and it doesn't necessarily coincide with the fact that a single organization has a big stick to hit people. It takes place through other legal instruments, it takes place through pressure nationally, it takes place through national enforcement, it takes place through the reaction of other states. You mentioned the IHR. The IHR has no police, has no clear enforcement clauses. And that's something I mentioned, I think, to interns when I spoke 2 weeks ago. But if you consider how incredibly transparent the world has become, and how the internet has made almost impossible for any countries, as socially controlling as it tries to be, to conceal big health problems that may spread internationally, it's impossible. And evidence shows it. If a country, for example, does not comply with its obligation, does not report to WHO, tries to conceal it, to fudge it, you immediately have counter-reactions by other countries. You may have countries starting arresting your nationals when they come to my country, put them in isolation, blocking your airplanes, freezing the imports of your meat, limiting investments. So doing what we call in international, we call self-help in a way. Reactions that play a positive role in ensuring that the United States complies with another obligation. When during the H1N1 flu pandemic in 2, 3, 4 years ago, China blocked the import of Canadian and American pork meat. Canada and the United States didn't go to us because the IHR in a way don't cover this or cover it very marginally. They went to WTO. And they started a process, not consultation, but anyway, raising concern that what China was doing had nothing to do with the cause of spread of the H1N1 flu. And whether or not it had an impact, but soon afterwards, China withdrew those trade limits. So in a way, the ways of the Lord are mysterious and infinite. And so it goes, I think, with international health law when it comes to enforcement.
You're absolutely right. And I'd like to give you just very briefly an example of how you can use the law as a very creative implement in changing government attitude. We have a client in our clinic, in fact she's still with us for other reasons, who was a volunteer worker in Thailand. A British national. She discovered she had breast cancer and returned to the UK for treatment, feeling that it was best to be near her family and all the rest. And the government, in its insensitivity, said, well, you've been working abroad, you weren't resident in this country, you can come here with pleasure, but you can pay for your health care. This is a woman who'd paid into the National Health Service for 40 years, and after she retired went to live elsewhere. There was a legal argument about whether she was resident, and residency was the issue legally. But we said, the students researched the matter, advised her, everything was fine. And then we had the conversation with the students, what do we now do? Because we don't really want to litigate this, do we? Because it's a worry for the client who still has breast cancer, unfortunately. So what we did was wrote to the local newspaper. The local newspaper got on the case immediately. They created a great big story. She was interviewed, she went on television, and lo and behold, the bill was withdrawn. So you can use legal rights as a tool for advising the client and then doing something about it without necessarily going down the route of formal enforcement.
Annette Counsel, tropical disease research. We've talked a lot about public education, access, law is or works in mysterious ways. One of the things that I notice when I come in contact with legal things is, at least to me as a scientist, it appears that when you're reading legal texts, you don't only have to deal with technical terms, but you also have to deal with a grammar and a way to put the words that seems to be from, 200, 300 years ago. So essentially, even when you find the definition of the legal terms, you still essentially need an interpreter. So my question is, just out of curiosity, why is that? Secondly, that really restricts severely your access to understandable information. Associated with that, there's a lot of scientific journalism that tries to translate, based on technical terms, science to the general public. Is there something like legal journalism? And finally, another element, let's say you really like this antiquated English, German, French, and whatever, and you find the terms, how do you actually find particular laws? Is there something like PubMed, where I can look up so-and-so keywords, and then it pulls me out, all the laws in the Bürgerlichen Gesetzbuch or wherever. And thirdly, or fourth or fifthly, is there something like open access legal journals like there are for science these days?
Okay, lots of difficult questions in there. The why, I guess all professionals, and I'm not using this in any defensive sense whatsoever, but all professionals guard their territory, and that includes introducing terminology that is private to them. It's not justifiable, but I think it explains why it exists. What do we do about dumbing down the law so it's understandable to people? I think one of the things my students find most challenging, they get the law right pretty quickly for themselves, but translating it into a format that the public can understand is much more challenging. And to a certain extent, you don't need to explain it in technical terms, but you need to be able to explain the consequences. And so my students will be able to say to the client, okay, the law generally says this, avoiding all the technical language completely, and these are now your choices based on that broad interpretation. I didn't make a note of all the points you made, so the last thing I'll respond to. Are there open journals? Yes, there are, and an increasing number. And there is a huge campaign, certainly in my jurisdiction. I can't speak for the civil law world, but certainly in my jurisdiction, there's a huge campaign to use what we would refer to as plain English. And that's creeping through now into court judgments, and it's creeping through into legislation. So I think things are changing. But in terms of the public's information, they're given that information on the basis of a lay person's understanding of the law.
I think Our colleague also wanted to know, is there a PubMed central version of law?
My students call it Wikipedia.
Well, just to add that I had your same reaction when I went to Wikipedia and looked even for the common cold. The explanation was so technical. They said, it's bloody doctors. I mean, why do they make it? Why? Because it's a form of control. It's a form of power in the end. If I make my language more difficult, it's more difficult for you to start getting on my turf. Sorry if I'm so cynical, but that's why. I mean, parliaments are composed largely of lawyers, that if they made a simple, easy, plain English law, they would be out of a job. So the issue is how to bridge the languages, and as Peter said, there are many ways. And there are also increasingly in the legal literature, there are books that address precisely your point. Law for non-lawyers. And so the human rights law, European Union law, and so really very accessible. Sometimes you miss something in the translation, but it's much more accessible.
One point that I think should be taken up is the rights of an individual versus the rights of a population health. And sometimes they are contradictory. And you have cases, for example, in the case of Brazil, where the right to health is enshrined in the Constitution, where individuals take the local authority to court for a very expensive treatment. And the local authority has to spend that much money with that individual, even when it means reducing public health protection for other people. So I think that's a case that when we are reflecting on this wasn't brought up, so I just thought I would.
Sorry, this is the last question. I don't want to be a bureaucrat, but this was really my personal opinion, and it's not WHO's official position. So if you go tell the Director General that I said all these things, I lose my job. So. Yeah.
I have a question because our colleague mentioned the Constitution and the importance of enshrining in the Constitution the right to health. I mean, India's had a constitution since decolonization, which in practice has said that every citizen of India has the right to health. But then you have more than 20 provinces or states that define that legal entitlement, but not just a legal entitlement, the whole notion of health in different ways. So how does the WHO then deal with local government? Because I know the World Health Assembly allows the WHO to deal with national governments. But in a country, a federal organization like India, Delhi actually has incredibly little power in relation to health in about 25 different political contexts right now. So how does a complex organization like the WHO then deal with these challenges legally? I mean, does it talk to state governments separately?
Hell of a question, and I think it touches the growing issues in many federal states, also Canada, the United States, Switzerland, Germany, where the local states get more and more power and the federal government has relatively little control. In WHO, unsurprisingly, since the member states sitting in a governing bodies are the central governments, there is a lot of deference to that. So WHO at the national level is obviously more prepared to the extent we can to assist local governments, for example, in translating international rules or translating federal rules. But we always make sure that the central government agrees to that. We don't bypass the central government, and that sometimes creates issues. We have that was done, for example, after the Framework Convention on Tobacco Control was adopted, because there was quite a lot of activities in WHO to help countries preparing for ratification. Basically, what laws should you adopt, what laws should you change, and so on. And there was a lot of that of comparing the central law with local legislation. That was done. You had central governments with local health authorities coming together to workshops, and that worked pretty well. So that's the kind of approach that we would normally follow.
Presentations. I'd like to thank all of you for joining us. We're going to take a short summer break, or not so short, depending on your perspective of how long a summer break should be. But we'll be back in October with a Global Health History seminar, which will have to deal with the theme of law as well and health rights. The topic is medical tourism, and again, lawyers being drawn into many national and local contexts where the private medical profession is actually offering services more cheaply than another context, and another marker of globalization. And then we will have another fantastic talk. The last talk of the series will be on the WTO and health, involving, I'm sure a colleague that many of you know, Ben McGreedy from Georgetown University, who has written a fantastic book on the topic. So we'll continue with the health theme. So this is a sales pitch to all you youngsters who've come to this talk. Don't forget us in October and December. So thank you, everybody. Thank you to the Wellcome Trust for supporting the seminar series, and thank you to all WHO colleagues for supporting us in every way possible. Thank you.